everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the neurology, that is the multiple sclerosis. So, if you see this multiple sclerosis, it is a demyelinating disorder. Right? And it is the demyelinating disorder of central nervous system and as well as the peripheral nervous system, but predominantly the central nervous system. And what exactly is the reason for the development of this multiple sclerosis? If you see the pathogenesis, it is an immune-mediated inflammatory disease, right? It is an autoimmune disease. So in patients with multiple sclerosis, the antibodies are formed against the myelin sheath, right? So these antibodies, whichever are formed against the myelin sheath, they cross the blood-brain barrier, right? They cross the blood-brain barrier and they damage the myelin sheath, and they also damage the axon of the neurons. Right? They also damage the axon of the neurons. Now, that myelinated axons in the central nervous system, they lose their myelin and as well as axon in variable degrees. So this particular myelin and as well as axon is being destroyed in variable degrees. Right, it is being destroyed in variable degrees, causing significant physical disability because of the loss of myelin sheath and as well as the axons of the neurons. There is significant physical disability within 20 to 25 years in more than 30% of patients. And this destroyed myelin sheath is healed by the oligodendrocytes by depositing the fibrous tissue in the destroyed area. So in these areas where the myelin sheath is being destroyed or axon is being destroyed by your antibodies, you have the fibrosis, that is accumulation of the fibrous tissue, right? Fibrosis or gliosis in brain, right? There will be fibrosis or gliosis, that is glial tissue gets accumulated in that particular area of destroyed myelin sheath and as well as the axon sheath, the axon. And the hallmark of multiple sclerosis is symptomatic episodes that occur months or years apart and affect the different anatomical location, right? So this particular destruction of the myelin sheath or the axon, it gets affected at different anatomical location. Right, different anatomic location is being affected. Now I'll just show you, right? So this will be the myelin which gets destroyed and different parts of the brain, they get affected, and there will be the fibrous tissue and as well as glial tissue gets accumulated within the various parts of the brain. Now what are the cells that will repair this destroyed axon as well as myelin? That is oligodendrocytes. Oligodendrocytes, they repair the axonal damage, right? They repair the axonal damage by causing gliosis, right? By causing gliosis. And this particular gliosis is represented in the MRI, right? This particular gliosis is represented in the MRI as the Dawson's finger, right? Dawson's fingers, or they are being represented as the plaques. I'll show you this, right? Or they are being represented as the plaques. And if you take the lesions, right, these plaques or the Dawson's fingers, these lesions of multiple sclerosis, they vary in size, right? They vary in size from 1 to 2 mm, right? They vary in size from 1 to 2 mm to several centimeters, right? To several centimeters. That is what the size of the lesions will be in patients with the multiple sclerosis, right? So you can see that these lesions, right, they are present mainly in the periventricular area, and the description of the lesions, if you see, these are called as these are called as the Dawson's fingers, right? And what are the cells which will mediate the development of these particular lesion? Definitely it is the infiltration of the inflammatory cells, and these inflammatory cells will be inflammatory mononuclear cells, predominantly T cells and as well as the macrophages, right? Predominantly T cells and as well as the macrophages, right? So these cells, they cause the disruption of the blood-brain barrier, and the autoantibodies, they cross the blood-brain barrier and they will cause the destruction of the myelin sheath, causing demyelination and as well as the axon. And the destroyed myelin sheath and axon is repaired by the oligodendrocytes, right? They will cause the deposition of the fibrous tissue. So there will be right, there will be gliosis, right? And within the MRI, you will also have the presence of the plaques, right? Within the MRI, you also have the presence of the plaques. So that is about the pathogenesis in patients with the multiple sclerosis. And if you take the etiology of multiple sclerosis, it is polygenetic, right? It is polygenetic. And which group of individuals are more prone for the development of this multiple sclerosis? Those individuals who have HLA-DR2 gene, right? Those individuals with HLA-DR2 gene, they have been demonstrated to be a genetically susceptible areas, right? And at the same time, you need to know what are the other disorders which are associated with the HLA-DR2, right? The other disorders which are associated with HLA-DR2 include narcolepsy, right, where they have excessive sleep in the morning, right, morning drowsiness will be there, and multiple sclerosis is the disorder which is associated with HLA-DR2, and as well as the good pasture syndrome, right? So good pasture syndrome, in these individuals, they have hematuria and as well as the hemoptysis, right? So you have the antibody formation in case of good pasture syndrome against the alveolar basement membrane and as well as the glomerular basement membrane, okay? So HLA-DR2 you have in all these, HLA-DR2 association you have in all these clinical scenarios. And apart from the polygenetic, we have what is called environmental multiple sclerosis. Now, what is this environmental multiple sclerosis? Environmental multiple sclerosis, it is more common in region with less sun exposure areas, right? So, in those places where there is less sun exposure, right? So, in those areas, you have this environmental multiple sclerosis, right? In patients with or in areas where there is less sun exposure, there is also lower stores of vitamin D, right? They also have lower stores of vitamin D. and that can predispose to the development of multiple sclerosis. And the other important etiology is multiple sclerosis has also been linked to certain viruses, and that is particularly Epstein-Barr virus. So these are the etiologies which will contribute to the development of multiple sclerosis. So those individuals with HLA-DR2 gene, environmental multiple sclerosis where there is less sun exposure, and third, Epstein-Barr virus, right? Now, after having discussed about the etiology causing the multiple sclerosis or predisposing factors for the development of multiple sclerosis, let me tell you, we have four important clinical patterns of multiple sclerosis. We have relapsing-remitting multiple sclerosis, primary progressive, progressive relapsing, and secondary progressive multiple sclerosis. Now, out of all these, which is the most common clinical pattern of the multiple sclerosis, right? Let me discuss that. The most common clinical pattern of multiple sclerosis is RRMS, that is relapsing remitting multiple sclerosis, right? That is the most common clinical pattern of multiple sclerosis. So these are the four clinical patterns: RRMS, then PPMS, that is primary progressive multiple sclerosis, then PRMS, that is progressive relapsing multiple sclerosis, then SPMS, that is secondary progressive multiple sclerosis. Out of which RRMS, it contributes to 85% causes of multiple sclerosis, and this will be the most common clinical pattern. Whereas you take PPMS, that is primary progressive, it is the rare form of multiple sclerosis, and not only that, this PPMS, it is also more severe as well, right? PPMS, it is also more severe as well, and no therapy is also available for this PPMS form of multiple sclerosis. Okay, now let me discuss the features of the individual types of multiple sclerosis. So you take the RRMS, that is relapsing remitting multiple sclerosis. As already I have said you, this contributes to 85% cases of multiple sclerosis, and the signs and symptoms typically evolve over a period of several days, right? For several days, you have the signs and symptoms of the multiple sclerosis for several days, and followed by that, the individual will get stabilized, right? Followed by that, the individual will get stabilized, okay, and stabilized, and they will also improve. The symptoms will resolve spontaneously or in response to steroids, right? He will get stabilized, right, where the symptoms, they resolve spontaneously or with the help of steroids, right, or with the help of steroids. And once the individual gets stabilized, once the symptoms, they spontaneously resolve or in response to steroids, the patients are clinically stable between the episodes, right? I'll just show you an image. So if you take RRMS, what did I tell you? You will have the episodes, and in between the episodes, they are completely stable, right? In between the episodes, they are clinically stable, right? And these patients with the RRMS, they may progress to the development of the PPMS, that is primary progressive multiple sclerosis. Okay, now I'll discuss about that, right? But in case of RRMS, whenever the symptoms appear, they will be there for a few weeks, and then they get spontaneously resolved, or with steroids they get resolved, and the individual will be stable between the episodes. So whatever, this is an episode, right? This is an episode, and this is an episode, right? And this is an episode. Between the episodes, the individual are absolutely stable. Now, coming to the primary progressive multiple sclerosis. See, primary progressive multiple sclerosis, they contribute to 10% cases of multiple sclerosis. And these individuals, they are characterized by gradual progression of disability. right? They are characterized by gradual progression right? They are characterized by gradual progression of disability without superimposed relapses. Right? There will be no relapses. Right? So without superimposed relapses, they will have the gradual progression of the disability. So I'll just show you the image of the PPMS. You see this? This is primary progressive multiple sclerosis. So you have gradual progression of the disease. There are no acute attacks, right? Over the time, these individuals, they gradually worsen. And another important form of multiple sclerosis is secondary progressive multiple sclerosis, right? Secondary progressive multiple sclerosis means the initial course right? The initial course will be RRMS, that is relapsing-remitting multiple sclerosis. That will be the initial course, right? And later on, they progress to SPMS, that is secondary progressive multiple sclerosis. I'll show you the image. You see, initially, the individual will be having RRMS, that is relapsing-remitting multiple sclerosis. And later on, there will be a progression of the disease. That is why it is called secondary progressive multiple sclerosis, right? That is SPMS, okay? And they are characterized by gradual progression of disability with or without superimposed relapses. So, you see here, there is no relapse. But here if you see the second image, there is a superimposed relapse. So, there may or may not be superimposed relapse, right? There may or may not be a superimposed relapse. That is what is your secondary progressive multiple sclerosis. And the rarest form of multiple sclerosis is the PRMS, that is progressive relapsing multiple sclerosis. This progressive relapsing multiple sclerosis, it is present in 5% of cases, and it is the rarest form of multiple sclerosis. And in these individuals, the disease is characterized by gradual progression of disability. Right? There is gradual progression of disability. Okay? From the onset itself, there will be gradual progression of the disability, and along with that, there will be also relapses, right? Along with that, there will be also relapses later in the course of the disease. That is what is your PRMS, that is progressive relapsing multiple sclerosis. So let me just show you this. You see this, from the onset, it is progressive disorder. It is not like secondary progressive. In secondary progressive, initially it is RRMS and later it was progressive. But whereas in case of progressive relapsing multiple sclerosis, from the onset itself, there is gradual progression of the disease, and along with that, you have intermittent relapses. Right? Along with that, you have intermittent relapses. That is what is your progressive relapsing multiple sclerosis. So these are the 4 important forms of multiple sclerosis, out of which relapsing remitting multiple sclerosis is the most common type. And primary progressive multiple sclerosis, it is the severe form and as well as the rarest form as well. Now, if you see the clinical manifestations of multiple sclerosis, which of the following is the most common initial presenting feature of multiple sclerosis? Optic neuritis, cerebellar ataxia, internuclear ophthalmoplegia, diplopia. Let me tell you, the most common initial presenting feature of multiple sclerosis will be optic neuritis, right? And if the question is asked, right, actually, it is not the visual manifestations which are more common. I'll tell you. So these are all the manifestations, right? These are all the manifestations that you will have in patients with multiple sclerosis. Visual manifestations, sensory abnormalities, motor abnormalities, and cerebellar abnormalities. Now, out of which the sensory abnormality, that is sensory loss, right, that is sensory loss, that will be the most common manifestation in multiple sclerosis, and that sensory loss will be in the form of the paresthesias, that is seen in almost 37% of cases with multiple sclerosis. Whereas optic neuritis, it is present only in 36% of patients. And the other features include weakness, paresthesias, diplopia, ataxia, vertigo, paroxysmal attack, and there is also involvement of the bladder. Now, let me discuss about the most common symptom. Actually, in this question, right, in this question, sensory abnormality is not there. So that is the reason why the next most common abnormality will be the optic neuritis. So that is the reason why option A is the answer. Next, then followed by that, if you discuss, if you see about this most common symptom, right, what will be the most common symptom? That will be the sensory loss. Right, most common symptom will be the sensory loss. Okay, and these individuals, they have abnormal sensations within the extremities, right, that is they can have paresthesias, right, and this sensory loss, it can be an early symptom as well, right, this sensory loss can be an early symptom as well. So the early symptoms are the sensory symptoms, and that will be in the form of the paresthesias. Okay, next, followed by that, the other important feature is the visual manifestations. Visual manifestations are very important in multiple sclerosis, and that visual manifestations will be in the form of the optic neuritis, where there is inflammation of the optic nerve, right, and this optic neuritis can progress to the development of the optic atrophy, right, can progress to the development of optic atrophy. And these individuals, they have a characteristic phenomenon called as Uthoff's phenomenon. Now, you should know what is this Uthoff's phenomenon. Mechanism I will tell you later, but Uthoff's phenomenon is nothing but worsening of vision following rise in the body temperature. Right, worsening of vision following rise in body temperature. Right, so that is called as the Uthoff's phenomenon. And in these individuals, the another important visual manifestation will be internuclear ophthalmoplegia. Right, there will be internuclear ophthalmoplegia. Internuclear ophthalmoplegia is a disorder of the conjugate lateral gaze. Right, it is a disease or disorder of conjugate lateral gaze. Okay, that is what is your internuclear ophthalmoplegia. So what is that exactly happens in internuclear ophthalmoplegia is, it is a disorder of the conjugate lateral gaze in which the affected eye shows impairment of adduction. Right, the affected eye shows impairment of adduction. Right, that is what is your internuclear ophthalmoplegia. Right, I'll show you an image also. And this internuclear ophthalmoplegia, right, this internuclear ophthalmoplegia, it is due to demyelination of medial longitudinal fasciculus. Right, median longitudinal fasciculus damage is the one which will cause this internuclear ophthalmoplegia. Let me show you an image. Right, this patient is having left internuclear ophthalmoplegia. So when you ask this individual to have a gaze towards left, right, the left gaze will be normal. In patients with left internuclear ophthalmoplegia, there will be normal left gaze. That means you consider this is the left eye and this is the right eye. And here what the left eye is doing, right, the left eye, it is showing or it is having abduction movement, whereas right eye, it is having the adduction movement. But what is the affected eye? That is left. What is affected in internuclear ophthalmoplegia? The adduction movement is affected. Now you see the next image. So the patient is asked to look onto the right side, right? Asked to look onto the right side. Then right eye will show you abduction, but left eye, there is loss of adduction. That is called as the internuclear ophthalmoplegia. So in the affected eye, the eye shows impairment of the adduction. And why is that due to? That is due to damage to your medial longitudinal fasciculus, demyelination of medial longitudinal fasciculus. So number 1, optic neuritis. Number 2, internuclear ophthalmoplegia. And another important ophthalmic manifestations in multiple sclerosis will be the Argyll-Robertson pupil. So you can remember this in the form of a mnemonic, that is ARP is your Argyll-Robertson pupil. So in these individuals, the accommodation reflex is present. Right, in these individuals, the accommodation reflex is present, but the pupillary reflex is absent. Right, the pupillary reflex is absent. And for the Argyll-Robertson pupil to occur in multiple sclerosis, where should be the site of lesion? The site of lesion should be in the pretectum. Right, the site of lesion should be in the pretectum. And what is the cause of the Argyll-Robertson pupil? Argyll-Robertson pupil, you will have that in multiple sclerosis. And other condition where you will have Argyll-Robertson pupil is diabetes mellitus, then in patients with pinealoma, next in patients with sarcoidosis, next in patients with neurosyphilis, you can have, right, next in patients with neurosyphilis, you can have the development of this Argyll-Robertson pupil, right? So these are all the causes for Argyll-Robertson pupil apart from multiple sclerosis, right? And secondary to this optic neuritis, the individual can develop blindness. So what is the treatment you will give once the individual develops blindness is methylprednisolone should be given, right? The drug of choice will be methylprednisolone. So secondary to this optic neuritis, there can be the loss of vision for which you need to give the methylprednisolone. And optic neuritis, it is characterized by loss of vision in the affected eye, and there is also pain upon movement of the eye. Right, there is also pain upon the movement of the eye, right? And the blindness, whatever is there, right, the blindness, whatever is there, it is either monoocular or binocular. Right, monocular or binocular. And much less commonly, patients with optic neuritis may describe phosphenes. What are these phosphenes? That is transient flashes of light or black squares in the visual field. right? Transient flashes of light or black squares in the visual field, that is called phosphenes, right? And these particular phosphenes, they last, the duration for which the phosphenes will be there is hours to months, right? The duration for which the phosphene should be there is hours to months. And phosphenes may occur before or during an optic neuritis event, right? So this will occur either before or during optic neuritis event, right? That is what is your phosphenes. And these phosphenes, they can be there even several months following the recovery. So what are phosphenes? That is transient flashes of light or black squares in the visual field, right? And they are called phosphenes, and they can be seen less commonly in these patients with the multiple sclerosis, right? Next, now followed by that, the Marcus gun pupil. This is another important visual abnormality in case of multiple sclerosis. So Marcus gun pupil is that where the individual has RAPD. What do you understand by the word RAPD? That is relative afferent pupillary defect. Right, relative afferent pupillary defect, that is what is called the RAPD, right? So the Marcus gun pupil is a relative afferent pupillary defect indicating a decreased pupillary response to the light. Right, indicating a decreased pupillary response to light in the affected eye. Right, decreased pupillary response to light in the affected eye. So we have what is called the swinging flashlight test. Right, so in case of the swinging flashlight test, right, in case of swinging flashlight test, the light is alternatively shown into right and as well as the left eye, right? So you see here the light, it is shown alternatively to right and as well as the left eye, right? So wherever the or whichever the eye, you see this is the normal response. Whenever the light is thrown, you have the pupillary constriction, but in that particular eye where there is relative afferent pupillary defect, whenever the light is shown, the affected eye, it will have a decreased pupillary response. That is what is called the relative afferent pupillary defect, which is nothing but Marcus gun pupil. Now, then followed by that, Argyll-Robertson pupil already I have discussed, where the individual will have accommodation reflex present, the pupillary reflex absent, and you will have that in diabetics, right? You will have that in patients with neurocephalus, and I have discussed many conditions where you will have this, right? In penialoma, in sarcoidosis, these are all the conditions where you will have this Argyll-Robertson pupil. Next, we have one more important visual abnormality in multiple sclerosis, that is called Pulfrich effect. The Pulfrich effect is seen in multiple sclerosis, chronic inflammatory demyelinating polyneuropathy, that is CIDP, then CRPS, then red-green color blindness. So where do you have this Pulfrich effect? That is seen in patients with multiple sclerosis, and at the same time you should know what is this Pulfrich effect as well. See, Pulfrich effect, it is a psychophysical percept wherein the lateral motion of an object in the field of view is interpreted by the visual cortex as having a depth component. Why is that abnormality? That is due to relative difference in signal timings between the two eyes, right? That is due to relative difference in signal timings between the two eyes That is the reason why the individual will have this Pulfrich effect. Okay, right? That is another important visual abnormality you will have in multiple sclerosis. So if you take all the visual abnormalities now, number one, optic neuritis. Number two, the presence of accommodation reflex, that is Argyll-Robertson pupil, right? Other visual abnormalities, Argyll-Robertson pupil. There can be Marcus-Gunn pupil. There can be development of blindness, right? And there can be the development of this Pulfrich effect. And there can be lesion within the medial longitudinal fasciculus, which is nothing but your Marcus-Gunn pupil. So these are all the visual abnormalities, and they can also have even phosphenes. So these are all the visual abnormalities that you can see in patients with the multiple sclerosis. And you see one important question, useless hand of opening in multiple sclerosis was described for devoid of proprioception, devoid of pain, devoid of temperature, all of the above. See, what is this useless hand of the Oppenheim? It was first described in multiple sclerosis. And another name for this useless hand of Oppenheim is, it is also called useless hand syndrome. Right, this is also called useless hand syndrome, which is nothing but deafferented hand, right, which is nothing but deafferented hand. Okay, so in these individuals, useless hand in the sense there is devoid of proprioception. Right, there is devoid of proprioception. So devoid of proprioception in the sense there is loss of vibration and joint position sense. Right, there is loss of vibration and joint position sense that often manifest the involuntary movements, right? So there is no sensation of vibration and the joint position sense is lost, right? You know, the individual cannot be able to tell or will not be able to tell what exactly is the position of the hand. Is it in the flexed position or is it in the extended position? He will not be able to tell this particular position of the hand, and that is called useless hand of the Oppenheim, right? And this particular useless hand of Oppenheim, it is due to demyelination of it is due to demyelination of the cervical cord segments. Right, that is due to demyelination of the cervical cord segments. That is what is the useless hand of the Oppenheim, right? And these individuals, so if you see this question now, useless hand of Oppenheim in multiple sclerosis was described for devoid of the proprioception. Now, apart from this, these individuals, they also have the demyelination of the corticospinal tract. Now, because of the demyelination of the corticospinal tract, these patients with multiple sclerosis, they have spasticity, that is increase in the tone, right? Increase in the tone in the anti-gravity muscles. So there will be spasticity within the biceps, right? There will be spasticity within the hamstrings, right? And because of the corticospinal tract involvement, there is also exaggerated deep tendon reflexes. Right, there will be also exaggerated deep tendon reflexes, right? They will have brisk deep tendon reflexes. And there is also presence of the Babinski sign. right? So what is this Babinski sign? It is upgoing plantars. Whenever you do a plantar reflex, there will be an upgoing plantar. That is what is your Babinski sign. And these are the features due to corticospinal tract involvement. Then, due to demyelination of cerebellum, right? What will be the features of cerebellar involvement? They have gait ataxia. Right, they have gait ataxia, and this gait ataxia, it is due to paleocerebellum involvement. Right, it is due to paleocerebellum involvement, and these individuals, they can also have, or they will also have, the truncal ataxia. And this truncal ataxia, that is due to demyelination of the archicerebellum. Right, that is due to demyelination of the archicerebellum. That will be the features of the cerebellar involvement. And in these individuals, there is also demyelination of the cranial nerves. And the cranial nerve demyelination involvement include trigeminal neuralgia. And because of this trigeminal neuralgia, they have the lancinating pain. Right, so in the sense, it is a shooting pain that the individual will have, secondary to trigeminal neuralgia. And these individuals, they also have glossopharyngeal neuralgia. And because of glossopharyngeal neuralgia, they will have difficulty in swallowing or painful swallowing. That is called odynophagia, right? And these individuals, they also have the involvement of the 10th nerve, that is demyelination of the vagus nerve, and due to which they will have aphonia. And because of the involvement of 9th and 10th nerve, there can be also nasal regurgitation of the fluids. Right, there will be also nasal regurgitation of the fluids. And at the same time, there will be also involvement of the 12th nerve, that is hypoglossal. So because of the involvement of the 12th nerve, these individuals, they cannot eat, because the 12th nerve is the one which will give the motor supply to the tongue. Right, it is the one which will give motor supply to the tongue. They can't eat. Okay, so these will be the features that you will have due to the involvement of the cranial nerve. Trigeminal neuralgia, glossopharyngeal neuralgia, right? Because of glossopharyngeal neuralgia, the individual has odynophagia and as well as nasal regurgitation of the fluid. And because of the 10th cranial nerve, there is aphonia, and because of the 12th cranial nerve, they can't eat. And there is also demyelination of the paracentral lobule as well. And due to the demyelination of the paracentral lobule is the one which will control the micturition, right? So now once there is demyelination of the paracentral lobule, there is inability to control the bladder. Right, there is inability to control the bladder, and due to which these individuals, they have bedwetting. Right, due to which these individuals, they have bedwetting. And then urge incontinence. Right, and they also have poor hygiene. So these are the features due to the involvement of the paracentral lobule. And these patients with multiple sclerosis, they also have the sensory manifestation in the form of pain. And this particular pain is related to demyelinating process itself. Right, that is related to demyelinating process itself. And this particular pain, it will be a neuropathic pain. Right, this particular pain will be a neuropathic pain. And this particular neuropathic pain, it is often characterized as having a burning pain, right? Characterized as having shooting pain. Right? So that will be the character of the pain in these patients with the multiple sclerosis, right? And apart from the sensory manifestation, that is pain, you take the urinary symptoms. Urinary symptoms, just now I have discussed, they are also common in multiple sclerosis, with most patients experiencing problem at some point in their disease, right? And patients with impaired storage, they have a small spastic bladder with hypercontractility of the detrusor muscle. And what will be the urinary symptoms? Just now I have discussed, that includes the urgency, that includes the frequency, right? And there can be also incontinence and nocturia. So these are the urinary symptoms that you will come across in patients with the multiple sclerosis. And these individuals, they also have constipation. Constipation may result. Why is this constipation? That is due to neurogenic bladder or due to immobility of the gastrointestinal tract, right? That is due to, it is neurogenic bowel. So there will be immobility of gastrointestinal tract, right? And this immobility of the gastrointestinal tract, it is due to it is due to neurogenic bowel. That is what is your reason why you will have constipation. Now, we were discussing about the Uthoff's phenomenon, right? Whenever there is rise in the body temperature, the symptoms of multiple sclerosis increases. Uthoff's phenomenon seen in multiple sclerosis is due to increased conduction of nerves, decreased conduction of nerves, destruction of nerves, recovery of nerves. Let me tell you, in Uthoff's phenomenon, there will be decreased conduction of nerves whenever there is high temperature exposure. So, Uthoff's sign is worsening of the symptoms, right? Worsening of symptoms of multiple sclerosis secondary to rise in the body temperature, right? Secondary to rise in the body temperature, right? So these high temperatures mainly due to the weather, right? Especially hot, humid weather. Right? Especially due to hot, humid weather. Or whenever the individual does the exercise, there will be rise in the body temperature. And whenever the individual is exposed to hot showers or hot bath, or the individual develop fever, in all those, there will be worsening of the symptoms. And why is that? That is due to whenever there is rise in the temperature, there will be impaired conduction by the demyelinated nerves. Right, there will be impaired conduction by demyelinated nerves. So that is what is the Uthoff's sign or Uthoff's phenomenon, right? So if you summarize all the manifestations, the most common presentation of multiple sclerosis will be the sensory abnormality, then followed by that the optic neuritis. So you see this question, multiple sclerosis, it is associated with all of the following except hydrocephalus, optic neuritis, spasticity, spinal cord involvement. Let me tell you, these individuals with multiple sclerosis, they don't develop the hydrocephalus, whereas optic neuritis, spasticity and spinal cord involvement will be there in patients with the multiple sclerosis. And this is the one, or this is the flowchart or table which will show you all the features of multiple sclerosis, right? Sensory symptoms, that will be in the form of paresthesias, dysesthesias, right? And the individual can also have pain. Motor weakness, right? Motor weakness, that is due to corticospinal tract involvement. They can have spasticity, hyperreflexia, and Babinski sign is being present. Visual manifestations will be in the form of optic neuritis, diplopia can be there, and the abnormal pupils, that is Argyll-Robertson pupil. Bladder and bowel involvement, right? The bladder dysfunction is seen in almost more than 90% of patients with the multiple sclerosis. And bowel involvement is the one where the individual will develop constipation, right? And there is also sexual dysfunction in these individuals, and they will have ataxia or dysarthria, that is due to demyelination of the cerebellum. And these individuals, they also have the facial weakness, that is due to lesion within the pons. And vertigo, that is due to lesion within the brainstem. And there is cognitive dysfunction and as well as depression. Fatigue is seen in almost more than 90% of individuals. And Uthoff's phenomenon I have discussed in detail. When there is raised body temperature, there will be worsening of the symptoms. Lhermitte symptom, I'll discuss what is this Lhermitte sign, which is very, very important. And cranial nerve involvement, that is trigeminal nerve neuralgia, facial nerve involvement will be there, glossopharyngeal neuralgia, vagus nerve, and as well as the 12th nerve gets affected. Now, let me discuss about, So let me discuss about the investigations. In between, I will just tell you about the Lhermitte sign or Lhermitte symptom. Very, very important. Now, the question is, which of the following test is not required for the diagnosis of multiple sclerosis? Lumbar puncture, gadolinium enhanced MRI, visual evoked potential, electronystatogram. So, which of the following test is not required for the diagnosis of multiple sclerosis? That will be electronystatogram. Whereas these three, that is lumbar puncture, gadolinium enhanced MRI, visual evoked potentials, these are all required for the diagnosis of the multiple sclerosis. And what will this gadolinium enhanced MRI will show? Gadolinium enhanced MRI will show you the presence of plaques, that is the Dawson's finger. And lumbar puncture, it will show you the presence of oligoclonal IgG bands. And visual evoked potentials will show you reduced amplitude of voltage generated due to plaques in the optic nerve. Okay, visual evoked potentials will show reduced amplitude of the voltage generated. And why is that? That is due to plaques in the optic nerve. And the criteria is called McDonald's criteria, which I will discuss that in detail. So the question is now, which of the following is the investigation of choice for diagnosis of multiple sclerosis? The investigation of choice in case of multiple sclerosis will be the MRI. And MRI will show you the presence of the plaques. And these plaques, they are present mainly in the periventricular area. And these plaques, they are of few millimeters to centimeters in size. And Dawson's fingers are seen in multiple sclerosis, multiple myeloma, Friedreich's ataxia, subacute combined degeneration of spinal cord. So the plaques, whatever I was discussing in the MRI, the plaques will be in the shape of the Dawson's fingers in the periventricular area, right? So the MRI, what it will show? The MRI will show you the presence of demyelinating, right, will show you the presence of demyelinating plaques. And these demyelinating plaques, how do they appear in the MRI? I have shown you that. That will appear in the form of that will appear in the form of hyperintense lesions on T2 weighted MRI. Right, that will appear as hyperintense lesion on T2 weighted MRI with active lesions showing enhancement with the gadolinium. Right, so these lesions, they will show enhancement with gadolinium. Okay, and where will be the typical location of these particular plaques? And the typical location of this particular plaques include in the periventricular area, right, in the corpus callosum, Next, cerebellar peduncles. Then followed by that brainstem. Right, and dorsolateral spinal cord. Right, so these are all the sites where you have the presence of the hyperintense lesions, that is demyelinating plaques. Whereas Dawson's fingers, they are present within the periventricular area extending superiorly into the corpus callosum. Right, extending superiorly into the corpus callosum. And what will this CSF show? The CSF will show you the presence of oligoclonal bands. And these oligoclonal bands, they are present in almost 90% of patients. And what does this oligoclonal band contain? It is IgG concentration. Then followed by that, right, the evoked potentials, that is visual evoked potentials. Visual evoked potentials that will show you the reduced amplitude in the optic nerve. Right, and why is that? That is due to deposition of the plaques within the optic nerve. Right, so the evoked potentials are delayed but well preserved the waveforms. Right, well preserved waveforms. Now, this is your oligoclonal bands. You see, in a normal CSF, the IgG, they are uniform. But whereas in case of multiple sclerosis, the IgG, they are clumped, resulting in what is called the oligoclonal bands. So, if you take the final workup, gadolinium enhanced MRI is the best test, right, where you will have the presence of the fibrotic plaques. Visual evoked potentials will show you reduced voltage due to the presence of the plaques in the optic nerve, and CSF will show you the presence of oligoclonal IgG bands. Now, coming to the diagnostic criteria. So, the diagnostic criteria is given by revised McDonald's criteria. So, this tells dissemination in space and as well as the dissemination in time. So, what does this McDonald's criteria says? That is, like, the individual should be having waxing and waning course of the symptoms. So, dissemination in time, you see for example, now the individual has 2 or more attacks. Right, 2 or more attacks. Okay. Now, after these 2 or more attacks, there should be a gap. That means the individual should be a completely symptom free. And after few months, right, after few months, there should be new gadolinium enhanced lesions. Right, there should be new gadolinium enhanced lesions. And these gadolinium enhanced lesions, the new gadolinium enhanced lesions are the one which will make the individual to have the appearance of the symptoms again. Right, that is dissemination in time. And minimum once the duration, the symptoms develop, the duration of the symptoms should be more than 24 hours. And dissemination in space. See, dissemination in space is the clinical evidence of 2 or more lesions. Right, presence of more than or equal to 2 lesions. That is what is your dissemination in space. Right. So, one lesion will be in the infratentorial area, other lesion in the juxtacortical area, the other lesion in the periventricular area. That is called dissemination in space. So, dissemination in time and dissemination in space. Whenever the new symptom develops, there should be a new gadolinium enhanced lesion in a different area. Right, you see this, right? The individual is having enuresis in the January. The individual is completely symptom-free in February, and this enuresis is due to demyelination of paracentral lobule. Then he has ataxia, that will be there for a month, and that ataxia is due to demyelination of the cerebellum, and the individual is completely symptom-free, and again he is having spasticity, that is due to demyelination of the corticospinal tract. So that is what is your dissemination in time and dissemination in space, and every symptom should persist for a minimum of the 24 hours. That is what is your McDonald's criteria. That is what is your McDonald's criteria. Then followed by that, we have some variants of multiple sclerosis. One is your neuromyelitis optica. Neuromyelitis optica, it is a scenario where there is severe optic neuritis and extensive transverse myelitis. Right, extensive transverse myelitis. Okay, extensive transverse myelitis in the sense there should be involvement of more than or equal to 3 vertebral segments. VS stands for more than or equal to 3 vertebral segments. That is what is your Devick's disease or neuromyelitis optica. And we have clinically isolated syndrome where you have single, right, where you have single multiple sclerosis like episode. That is what is your clinically isolated syndrome. Then we have the fulminant multiple sclerosis, which is nothing but Marburg. So here in this fulminant multiple sclerosis, the word itself tells you fulminant. That means it is rapidly progressive and fatal multiple sclerosis. Right, rapidly progressive and fatal multiple sclerosis, and this is associated with axonal damage. Right, this is associated with axonal damage, associated with axonal inflammation, associated with axonal necrosis. That is what is your fulminant multiple sclerosis or Marburg, right? And neuromyelitis optica, I have discussed that separately, which is also called Devick's disease, right? I have discussed a separate section on the neuromyelitis optica, okay? Next, now coming to your Lhermitte sign. So, in the symptomatology, what I was discussing in the flowchart, I said you the presence of Lhermitte sign. What is this Lhermitte sign? These patients with multiple sclerosis and as well as cervical spondylosis also, you have this Lhermitte sign. Whenever the individual does the flexion of neck, right, whenever the individual does flexion of the neck, that will cause electric shock sensation right, that will cause the electric shock like sensation down the spinal cord. Right, electric shock like sensation down the spinal cord into the legs. Right, that is what is your Lhermitte sign. Okay, and this Lhermitte sign, it is also called barber chair sign. Why? Because whenever we sit in front of the barber, right, we need to flex the neck, right, in order to have a proper haircut. So what are all the various etiologies where you can have this Lhermitte sign? Number 1, multiple sclerosis. Right, number 2, cervical spondylosis. Number 3, subacute combined degeneration of the spinal cord, that is due to vitamin B12 deficiency. Number 4, compressive cervical myelopathy. Right, compressive cervical myelopathy. Then radiation myelitis. Then followed by that pyridoxine toxicity. Right, so these are all the conditions and even inflammatory pathologies like SLE. These are all the conditions where you have the presence of the Lhermitte sign or the Barber chair sign. Now, so this completes the discussion of the investigations and symptomatology in patients with the multiple sclerosis. Now, let me discuss the treatment in these patients with the multiple sclerosis.